Hello, everyone, and a warm welcome to our Fellows Public Talk series. I'm Claudia Rizzini, the Executive Director of the Radcliffe Fellowship Program here at Harvard University. Before I introduce the speaker today, I would like to encourage everyone to ask questions. You can do so at any point throughout the program. We will address them at the end of the talk. And you can ask your question by using the Slido links, which is posted here on the side of the podium, and in the chat feature of the Zoom webinar for our online audience. Thank you. It is my pleasure to introduce Kelly Irwin, our Jeffrey S. and Margaret Mais Padnos Fellow. Receiving a cancer diagnosis is a life-changing event for everyone. For individuals living with serious mental illness, such as schizophrenia or bipolar disorder, the effects are compounded. Adults with serious mental illness die up to 20 years earlier than those in the general population, and are more than twice as likely to die from cancer. Kelly is dedicated to helping close this jarring mortality gap and improving the quality of care that patients receive. As director of the Collaborative Care and Community Engagement Program at Massachusetts General Hospital in Boston, Kelly leads a team that aims to provide specialized cancer care for individuals with serious mental illness. She has developed a care model that partners psychiatry, oncology, and social work to collectively coordinate care and address challenges in an individualized way. While at Radcliffe, Kelly is examining the collective stories of the patients, doctors, and caregivers who participated in a first-of-its-kind randomized clinical trial for patients with mental illness and novel cancer diagnoses. Kelly serves as an advocate for the right of people affected by disabilities to receive comprehensive care with dignity. At its core, the goal of her work at Radcliffe is to disrupt the narratives we share around mental illness. The Q&A portion of the public talk today will be moderated by Shelley Greenfield, who is the Mary Beth and Chris Gordon Fellow here at Radcliffe and Professor of Psychiatry at Harvard Medical School. And now please welcome Kelly Irwin.
Thank you so much, Claudia. It is my great privilege to be here with all of you, and I'm so grateful to the Radcliffe Fellowship for creating a community like this where we have the opportunity to bring different parts of our identity into the conversation. We're at Radcliffe. We're going to talk about women today in particular in the context of my work, and I wanted to start with two. This is Susan Sontag, as she writes, "Everyone who is born holds dual citizenship in the kingdom of the well and in the kingdom of the sick. Although we all prefer to use the good passport, sooner or later, each of us is obliged to identify ourselves as citizens of that other place." Susan Sontag is writing about breast cancer when she writes these words. She could certainly also be writing about mental health disorders. And so I'd ask you just to take a minute. We're going to move to the next woman to help us do this too, but take a minute and think about how you've been affected by cancer, how you've been affected by depression or bipolar disorder or schizophrenia or addiction, and hold that in your mind when we think through the narratives we're going to learn about as part of the talk. Here we have another wonderful, strong woman who's writing after her diagnosis of breast cancer. "I was forced to look upon myself with a harsh and urgent clarity that has left me still shaken but much stronger. I was going to die whether or not I had spoken. My silences had not protected me. Your silence will not protect you. The fact that we're here and I speak these words is an attempt to break that silence and bridge some of the differences between us. For it is not difference which immobilizes us, but silence." You see her there. Women are powerful, dangerous. And I agree that sometimes it is the visibility that makes us vulnerable that is also the source of our greatest strength. And with that preamble, I wanted to share a little bit about my story. When I was a third-year medical student, I ran 8 miles a day and then came home to my room and pounded for another 2 hours. I couldn't sleep. I was restless, highly irritable. I felt unsafe. I did very well in medical school, but my thoughts increasingly got more and more out of control. I would run along the night in the river, and I would think about jumping off bridges. I would have a hard time focusing in class. I ended up feeling less safe in my apartment than at work. I went to my clerkships earlier. I came home later. It was very good for my academics, not awesome for my well-being. I was lucky enough to have been connected to a therapist at medical school. Someone else made me go. And one night after my clerkship, I walked over to her office. And she said, Kelly, you're not gonna go home tonight. You're gonna go to the hospital. And I said, but what about your other patients? And she said, it doesn't matter today. I'm going to take you to the hospital. And I went to the hospital. And that was really important for me to get connected to better treatment and be able to get better and live chronically with my bipolar disorder. When I mentioned to my youngest daughter that I was going to talk about my mental health history, she said to me, you were in a psych ward? And I said, yeah, and she's like, you know what, Mom? That's great, because isn't that where you would get treatment for depression? So that sounds like what you needed to do. I'm really glad you told me about that. I say this because while we're listening to the story, sometimes it's easy to say, oh, those other people over there with bipolar disorder or schizophrenia. But that's not really the reality of how mental health disorders affect us in our community. It's us over here. And sometimes it's easier to remember that when it's also someone who's a Harvard fellow and a physician who's sharing that narrative with you. So I hope we can all hold that together as we go through the talk. Okay, so if you Google Cancer Center and you Google mental health clinic, these are some of the images that emerge. When I see these images, I am struck by a glass cancer center that we invest millions of dollars in, contrasted with a strip mall. In addition to the differential investment of resources, it becomes the burden of the patients and families to traverse those two separate systems, as clinicians don't frequently work in both of them. When we organize or fail to organize a system in this way, it has grave consequences that speak to the need to do things differently. There were good ideas. People had wishes and hopes when they were thinking about community mental health care. People had wishes and hopes when they built the Lindemann Mental Health Center. That's the chapel over there. I don't know if you guys have been here. It's right across from MGH. But unfortunately, those wishes were not actualized. We did not invest adequately. We do not have an adequate community mental health system that's anywhere near what we need. This building complex has a bunch of stairways that go nowhere, and fences and no green space. It's a disaster. It's 1 block from MGH, and I think many people have never walked inside. What happens when we set up fragmented systems like this? People die way too early. So in the great state of Massachusetts, women with serious mental illness who are under the care of the Department of Mental Health die 30 years earlier than women without serious mental illness. And 80% of that mortality gap is from medical illness. The number 1 cause of death is cardiovascular disease, and the number 2 cause of death is cancer. And that is why I study the intersection between cancer and mental health care. Because all along this continuum of cancer care, from how likely it is to offer people help with quitting smoking, to the rates of mammography screening, to lung cancer screening, to how likely it is to be recommended guideline concordant cancer treatment, mastectomy versus breast conserving therapy, to how likely it is to be referred to palliative care. There are inequities in care all along this cancer care continuum, and they contribute to differences in quality of life and 2 to 3 times greater cancer mortality for many common cancers. The only good news here, if you want some good news, I want good news, is we can do something about it. It's a modifiable gap. What we found is that one of the key predictors of whether or not someone is able to get equitable care is whether or not they have access to a psychiatrist at the time of cancer diagnosis. So I'm encouraged by that, because that's something I think we can do something about. Oftentimes when we think about a disparity like this, I feel we spend way too much time talking about all the stuff the patient's not doing or doing, maybe even their health behaviors. So yes, patient-level factors contribute to this disparity. There are high rates of smoking, psychiatric symptoms make it challenging to communicate and talk. There's high rates of poverty, and people are more likely to be unhoused. But if we delve a little more deeply into that, there are also many clinician factors. Clinicians are uncomfortable talking about mental illness. We lack training across disciplines, and we lack the time that's necessary to care for people with complex needs. As this oncologist says, it's easy to feel overwhelmed. We're not trained to talk about cancer, with schizophrenia front and center. And then if we think about the structural factors which we've laid out for you, quite simply, psychosocial care is inadequate. It's not there. Even at the world's greatest hospital, in the most resourced city, we do not have adequate mental health care for the people who need it. And one of the biggest barriers is that lack of access to psychiatry. And you can't send someone to a clinic, wait 6 months, and then have them see another person when they have cancer. Things have to move faster than that. And finally, from an equity perspective, 1 in 2 clinical trials excludes individuals with mental health disorders. That's mental health disorders and addiction. That's 1 in 4 United States people. It's 1 in 4 people in this room, probably a little higher. Anyway, it's a human rights violation. There's not a clear rationale for why this exclusion happens. And this is a problem because we lack an evidence base to know how to care for this population, and because cancer clinical trials are sometimes the only way to get life-saving treatment. So in summary, mental health discrimination, meaning legal acts, like if we're thinking about mental health as a disability, that's pervasive. And if we keep doing stuff the same way, we will worsen those disparities. Brain illness, too often, remains invisible and unspoken. This contributes to feelings of shame, shame being the sense that I'm not lovable. There's something so fundamentally wrong about me that no one will ever love me. And isolation, which can lead to delays seeking care, whether that be cancer care for a breast mass or mental health care for depression. Clinicians often feel helpless. When you learn helpless, you don't know what to do, you don't have a clear next step. That makes us make more assumptions and contributes to being less likely to deliver guideline-concordant cancer care, to prescribe tobacco cessation medications, to refer to a clinical trial. We don't adequately invest in any of this, in mental health services or training or research, and we need better data. So all I wanted to say about this is that I think dignity matters. Dignity is a big word, people think about it differently, but when I'm talking about dignity, I'm talking about this intrinsic dignity, or sense that people matter not because of what they produce or what they achieve or how useful they are, but because they're a human being. And the way we treat people with mental health disorders is counter that. Remember the pandemic, it wasn't so long ago. We were talking about, people with disabilities have equal access to ventilators. This is a really big conversation and a really clear sign of how we value people in the United States. And we have to be thoughtful about how we approach shame. Shame is a toxic emotion. It's toxic for human beings in general, for patients, for clinicians, but there are effective ways of learning compassion that can address that and help people feel heard and seen. And then finally, what happens when you witness this kind of a system fail and you keep doing the same thing? That's moral injury. It's happened to so many clinicians and other people in the world as they've witnessed the discrimination that happened during the pandemic and other contexts too. But I just want to bring that into the room because when I think about our model and why it matters to me, in part it's because it decreases my moral injury to work in a way that I feel is effective and person-centered. So autonomy, an important medical value here in the West, for sure. Autonomy, having choice, having the ability to make your own decision and be supported in that. What happens if, let's say, you're a clinician or perhaps you're a family member and you hear someone you care about, a 50-year-old woman who you hadn't been in touch with for maybe 3 or 4 years. She'd become unhoused. She found out that she'd had schizophrenia. She'd actually been able to get into a group home. She was doing well, and had found that she felt safe in that group home. She was finally referred to a PCP after 10 years out of medical care. On an X-ray, he found a new large lung mass. She was so scared that she literally fled, ran with her feet 4 miles across town. She eventually came back to the group home, but was very disorganized, wasn't making sense, wasn't engaging with anyone, was acutely paranoid. She persisted. People tried to speak with her, encourage her, let her know that there were things that they could do, but she couldn't engage with them. She coughed more, she lost more weight, she started to cough up blood. What do you do? Well, she said, when we asked her, Dr. Irwin, she said, I don't need to see a doctor. I'm fine. I'm okay. Well, I'm concerned, I'm worried. I'm worried that you might have something in your lungs that's affecting your health. I would like to try to help with it. There's nothing in my lungs. I'm good. Leave me alone. What would you do? Well, I'll tell you that there are many people who told me to leave it alone. Leave it alone until she's actually coughing up so much blood that it's clear that she needs to urgently medically go to the hospital. I'm not sure. This is a gray area. Is there a way that we could work with people? What I'll share with you is that oftentimes there is. And although nobody wants to have cancer treatment is not something we want. Also, no one wants to die of a progressive, painful tumor that makes it hard to breathe. My guess is, and having known this person, I will share that she really doesn't want to have to leave her group home, a place that she finally feels safe at. So what might we do about that? Maybe we could make it clear that getting treatment doesn't mean not leaving your group home. And so this person, who initially declined cancer treatment, she came to the hospital. We had to initially have her come involuntarily. But when we did that, we had her met with an oncologist and me and a primary care doctor. We admitted her and she had a complete workup so she could make an informed decision about what to do about her lung cancer. Initially, she said, and maybe I'll try the radiation. That doesn't seem that bad. And later than that, she said, okay, maybe I could do the chemotherapy. And later than that, she said, you think I could quit smoking? I smoke 4 packs a day. I'm like, I think you probably would feel better. You want to try? You don't have to quit totally. She cut down, she quit. She came to the hospital every 2 weeks on her own. She wore a leather jacket just like that. And what I would offer is that what she said about that and her autonomy is, they made me feel like I mattered, like I had a choice. So that's the framework we bring to our work. It's a clinical research program. We developed a person-centered collaborative care model. We'll talk a little bit more about that and have rigorously tested it in a single-site randomized trial and are hoping to bring that to the community. We also have a clinical program, and we collaborate with community mental health agencies and a broader coalition, which I'm certainly all are welcome to join, but join just by the fact that we all agree that mental illness should not be a barrier to cancer care and research, and hope to be a source of information and advocacy when people need it. So what is the bridge model of collaborative care? So collaborative care is a population-based approach that aims to increase reach to psychiatry. Because psychiatry is limited, we want to be thoughtful about how do we use that limited resource as effectively as we can. We embed a social worker within the oncology center, and that social worker is then able to rapidly consult with the psychiatrist who's able to see more patients. All collaborative care models are team-based in this way. They also use evidence-based approaches, brief behavioral interventions that are effective. They track symptoms rigorously. And in this case, we're also very focused on whether or not people are getting guideline concordant cancer care. So when we say, I can hear my pager, we say evidence-based treatment, what we mean is not just evidence-based mental health treatment, but also evidence-based cancer treatment. And every week, the team comes together and reviews whether or not the person is receiving evidence-based cancer treatment and rapidly adjusts treatment if that's not the case. And the team approach in this case also includes the social worker and psychiatrist coming together with the oncologist to develop a collaborative treatment plan. So that's the bridge model. It's a little more intensive than your average collaborative care model because it's two specialty conditions at the same time. And it's also grounded, as I've realized more directly in my head, in the principles of dignity and how we do that. Because when we think about how we address shame, one of the key things is being able to be vulnerable. So like I was when we started the talk. And as Audre Lorde guides us to, and Brené Brown, the only way to really move forward, right, and toward growth is to be vulnerable. And what vulnerability makes possible is connection. And this is equally true in clinical interactions. I'm not saying that I'm disclosing information, but I'm creating a space where the person feels able to be seen and heard and can grow from that relationship. And that's a fundamental part of what we do. So as the navigators that I've worked with have taught me, and many patients, trust is earned. It is not a given. There are strategies that we can use, though, to earn that trust. To begin with what matters to people, you can ask people, what matters most to you? You can ask people, what's important for your team to know to care for you the best we can? That's called the patient dignity question. And do something helpful at the time. Listen and repeat back what you hear. Make eye contact. This was during the pandemic. It was especially important with masks. Do what you say you're going to do. So be careful about what you say. Make sure you can do it. Or at least do your best. And keep showing up. Be persistent. Don't expect that things will change in one interaction. So that's the model. This is the design of our randomized trial that we conducted between 2019 and 2021 in 120 patients with schizophrenia, schizoaffective disorder, bipolar disorder, or severe major depression, and a new diagnosis of a solid tumor that could be treated with curative intent, and 60 of their caregivers. It was a 12-week trial with another follow-up for 12 weeks. And the primary outcome was whether or not they got guideline concordant cancer care. We also investigated changes in their psychosocial symptoms and psychiatric illness severity. But the big question was, okay, so people on this bridge arm, compared to enhanced usual care, which was just informing people of resources, were they going to be more likely to get the cancer care they needed or not? This was a question. People were not sure. A psychiatrist, is that really going to make them more likely to get their cancer care? Is that the outcome that matters most? From my perspective, yes. I feel this was the outcome that mattered most to most of the patients that we were working with. And it also is one that's on the pathway to survival. It's not the only outcome, but I think it's an important one to look at. So the take home is that patients who were on bridge had 1/2 the rate of cancer care disruptions compared to those on EUC or enhanced usual care. They also had decreased anxiety that they reported themselves. They also had decreased psychiatric illness severity, or overall how sick you are, assessed by a clinician. And beyond that, I think that in the narratives we also hear that people felt that their dignity was upheld in a way that it hadn't been previously. And Carmen, I'm sharing her name because she's part of our coalition, so she has chosen to share her narrative, and she has a blog on our website. That's why you see her face up there. This is lesson 2 about dignity. We had autonomy. This is being heard as a person and advocating for your patients when they're dismissed. As Carmen says, they'd forgotten about me. I was just a number. Carmen is a Latina woman who is a lesbian, who has 5 children, one who was a 2-year-old, was coping with many competing stressors. And as she says here, after so many failures, you tend to develop a certain distrust in the professionals. Doctor made me feel that I was just as important, that she wanted me alive as much as I wanted myself alive. Every single time I told her something was wrong, that my doctors were dismissing me, which was a lot of times, she believed me. I honestly believe I wouldn't be alive today without Bridge, because there wasn't a single person listening. Or better yet, because of my tattoos and piercings and the color of my skin, I think people thought I wanted to exploit the system. I'm a proud, educated Latina. My complaints fell on deaf ears. The Bridge team put that aside and I was able to have people treat me just as a human. Okay, dignity 3, creating space for vulnerability. Why sometimes 24 weeks wasn't enough. The call for continuity of care and why it really matters to have rapid access to expert psychiatry care. This patient was 25 when she was diagnosed with breast cancer. She had just had a 2-month-old daughter. Her childhood had been notable for her father dying of suicide and her mother dying of an overdose. She attended college, was very intelligent, had a great deal of difficulty managing distress, had a diagnosis of bipolar disorder, had an eating disorder. And when she entered into the trial, she did the trial to help other people. She was doing just fine. She had it together, but she did want to help other people who might have had mental health needs to know about the importance of psychosocial care. And through the trial, unfortunately, her mental health worsened. She experienced significant depression. She needed to be hospitalized multiple times. Her eating disorder worsened. She coped with many challenges and also hung in there and got through her cancer treatment and was able to engage meaningfully in her mental health care. She spoke about how in the beginning it was very difficult for her to tolerate meeting with me, that she wasn't used to someone calling her on stuff as much as I did, and that was painful and difficult. She wondered if she actually would have stuck with it if it hadn't been for the trial. As she said, "I have never worked with someone as caring or as consistent. It was because of her that I was able to continue Herceptin, it's a medication for breast cancer, when she was in another hospital for her eating disorder. She told me, I didn't really care about it, I'm done. I don't care if I'm on it's one more thing." I was like, well, I care about it. I think we can make it happen. We can ensure there's not a 3-week delay in your Herceptin. This is across town, let's make sure that you take it. As she said, there were times when I would have given up on treatment. I also wanted to discuss this next vignette because it reminds me of where we started about hospitalization. As she says here, "I went to the emergency room because I was very escalated." In other words, she was having thoughts about ending her life and self-harming and out of control with those thoughts. She went to the emergency room, she calmed down, and the psychiatrist on site planned to send me home, but needed to call Dr. Irwin. When he called, it was like, "No, you're staying. You could stay, or do you want to sign in voluntarily?" So not really super good choice there for her. It was sign in voluntarily or be committed involuntarily. Now she said, "I was so angry. I was so angry because I just wanted to go home." And I remember her texting me. She was in the hospital that day and she asked, "Do you want me to come see you? If not, that's okay. I know you're angry." The fact that she gave me that choice meant a lot to me. I still hold on to that. Even though I was really angry at her, I felt comfort in seeing her. It definitely helped my relationship with her. I frequently get asked about whether involuntary hospitalizations fracture a relationship with someone who I am caring for. And my response is, it very much depends on how you accompany someone through that experience. My experience is that if you're doing the right thing for someone and you show up and you explain that, yeah, they're going to be angry. And usually you can work through that. Now, there are caveats to that, of course. And there are times when I cannot involuntarily hospitalize someone because I am worried that they are Black and they will be harmed, maybe even die through this process. So I don't want to minimize those elements that need to be changed in our mental health system. But I will offer that I've had multiple experiences where I have encouraged/made my patients come to the hospital because I was worried about them medically, because I was worried about them psychologically, because it was important that they knew somebody cared enough to try. That's meaningful. It was meaningful for me. I didn't want to go either. When you're in a state of depression and ruminative thinking, that's what happens, you stop thinking straight. And so hopefully, we all are lucky enough to have someone who's caring for us that we can trust enough to say, okay, that's the wish. That would be adequate, effective mental health treatment that I wish everyone with cancer could access. We're not there yet. All right, so, and back to where we started with our first case. So this patient actually did really well. It was actually right when lung cancer care was fundamentally changing. She'd originally been diagnosed with an advanced stage lung cancer, and back, even 5 years prior, most people died within 2 years. But she actually was able to transition to immunotherapy and responded to it and did well for 5 years. Unfortunately, she stopped responding to the immunotherapy. And then we navigated another challenge in dignity in her care. Would she be able to stay at the group home that was so important to her? Would she be able to have oxygen despite the fact that other people in the group home smoked? Would the staff feel adequately trained to provide hospice care for her? This was a challenge. We kept her in the group home. She was able to stay until just the last 3 or 4 days of her life. We went and did some training about how to manage things with the group home staff, which I think was very helpful. And then she transitioned to a hospice house, and our navigator was able to visit her there. And I wanted just to share the thoughts from the nurse practitioner who had originally referred this patient to our program. Well, I'm overwhelmingly saddened regarding her death. I'm so glad that she passed away on her terms, making informed decisions about her health and how she wants her body to be treated in her passing. She remained in her residence until a few days before she died, which was of utmost importance to her. Meeting her on her terms from the beginning is what enabled her to have those 5 years. And interestingly, those 5 years were some of her healthiest psychologically. When she was coming to the hospital every 2 weeks, she would joke with us. She was out in the community more than she had been. I didn't think she did feel in some ways held by the context of cancer care. And looking back, it's hard to look back, but when I asked her, what are your thoughts about this? What are you thinking? And then she was really responding to someone coming to the group home and thinking through her hospice decision making. And she said, I never thought anyone would do this for me. I never thought anyone from the medical system would help me to have a dignified death, right? Like, that's a big thing. That if I get to do that, that's a way that's worth it to spend my time. The more times the doctors get to do stuff that they think's worth it, that their patients think's worth it, that makes a meaningful difference, that will also decrease moral injury and help us all feel a little bit more like we're giving the care that we want to give. And I think that's positive for clinicians also. Sometimes people say, oh, this is so not scalable. It's just that you're just such a freaking good doctor. You're so dedicated. You're an angel in the system. And I will offer to you that that is not the solution here. That even if I worked hard, I absolutely could not have done this without a very dedicated team. But also that it's not about spending more time. It's about identifying people proactively and choosing how you spend your time. We have this challenge where we're always adding more care coordinators, but there's no care to coordinate. So I would encourage us to invest in actually having that specialty care and enabling it to be delivered flexibly. The challenge is moving away from billable models, but we have great examples of doing this in substance abuse, for example. There are new paradigms that we can think about. Beyond that, to really move the needle from a social justice perspective, we can't have a single academic trial at a cancer center. Even for this trial, it was very important to me to make sure we were engaging the people who would not yet have made it to the cancer center. In my other job, I worked as a medical director of a clozapine clinic in a public mental health clinic that was connected with the Department of Mental Health. And with the support of the Department of Mental Health, we were able to collaborate with them to ensure that we could identify people also in community mental health agencies so that we could help them more quickly get to the cancer center
and then maybe be able to participate in this research. And what we did is we created a coalition called the Engage Initiative, which was intended to build the capacity to do research together that's guided by a community advisory board that includes people with lived experience and clinicians and researchers and payers, but also delivers like clinical care and is still, this was started in 2017. We met last week. It's another thing that gives me a little more hope about the good people in the world. And another thing we could think more strategically about having targeted, sustainable funding to support, because it is hard, as many of you know, to do community engagement work and to do it right. It's not a small investment of time. It's a large investment of time that's incredibly important. So in terms of dignity and why I do this work and what grounds me, so these are my 3 daughters. So this, are they almost in order? I think they are. So it's Juliet, Vivian, and Addie. And people ask me why I do this work, and I do it because I feel it's what I'm supposed to be doing, and if I'm not going to be with them, I'm going to be doing this good stuff. And that is Amy Corvaline, who's the social worker on our trial, who is equally important to me in making this work happen and enabling people to feel that they're receiving expert care with dignity. I'm very grateful to the many, many partners and supporters who have been part of our work, to all of you for listening, especially to the patients and participants in the trial, for generously sharing their narratives with me. Thank you very much. I'm a clinician, so I have to check my pager, because I heard it go off twice.
So I'm reminded that that is a very common scenario for physicians who are up giving public talks while their pager is going off in the distance and there are patients waiting and others to talk with them. So I heard it myself, and if I could have answered it for you, I would have. So we'll wait for one moment.
I don't think it's an emergency, so we can go on.
That's great.
Thank you. I appreciate that.
Yeah, absolutely. So I'm supposed to just first remind all of you that you can send in questions via Slido. So with that, I just want to turn to you. And first of all, I want to thank you so very much for this incredibly comprehensive, informative, and very inspiring talk. And particularly the sharing of 3 great women and their stories at the beginning, which I think is very important for all of us because it enables us to hear from folks, in this case, Susan Sontag, Audre Lorde, and yourself, about your experiences with illness and how that feels and how one manages and how one actually begins to cope with those things and rely on others. So thank you for that. I think I speak for everybody that all 3 stories are very inspiring to us. And also, I just wanted to say one other thing you said at the beginning, which really struck me, which is your daughter. When you talked to your youngest daughter, and I saw the 3 pictured, so that's a little girl, and you explained what you were going to do today, she immediately said, well, that's great, because that's where you get treatment. And I often say to people that stigma that we see in our society around mental illness and mental health, we don't see it as much in younger people, and that there, I believe, is a secular change that is happening in our society as people talk more and more about all of these issues and actually acknowledge the fact that mental health issues occur in so many people, and all of us are affected, family members and ourselves. So I really was struck by your daughter.
I was struck, and I'm sure many people know the story better than I do, but as I reread Audre Lorde's essay, one of the pieces in it that really moved me when she was thinking about speaking when she feels vulnerable, she asked her daughter, and her daughter said, well, you just tell them, if you don't speak it, it's gonna get hotter and louder until it comes out, because it's part of you. She said it better than that, but I think it's the same idea that our children want us to be genuinely ourselves.
Yes.
And that's the wish for all of us.
Indeed, I think so too. So I want to ask you a couple of questions because there's really so much in your talk, and I'm in getting to know your work, I'm very inspired because I think you're really working in an area of great health disparity. And as you point out, there are multiple different levels on which we need to work to make this better for people, for all of us. So just to start, here's one question. Stigma, shame, and discrimination. These are words, we often use interchangeably. They're actually not precisely the same, as you pointed out. And, you spoke briefly about Susan Sontag and her experience at the beginning of your talk. You highlighted that when she had breast cancer, that was highly stigmatized, and people did not discuss breast cancer openly. So I'm wondering if you could comment on what changed that dynamic in the United States for breast cancer, and what do you think would have to happen for schizophrenia or bipolar disorder to be discussed more openly and be the target of less discrimination in our society, and especially, as you point out here, in the medical system?
So I think there are two big pieces. I think that first, cancer care has advanced so incredibly since the 1970s. We've gone from 75% of women living with breast cancer to more than 90%. Because treatment keeps getting better. Because we rigorously invest in biopsychosocial treatments, and unfortunately not all people benefit from them, but if you have access to them, you're much more likely to live. And we talk about that. We talk about how much better breast cancer treatment is, and people see people living after their breast cancer treatment. So I think there's two pieces to that. One is that we need better treatment for schizophrenia and bipolar disorder. Two, we need to talk about it when people do get good treatment, which was part of my motivation for sharing my treatment with bipolar disorder, which has been pretty helpful for me. And here I am. So I think that the more we bring things into the open, yes, but even more than that, we need better treatment.
Yeah, can I just ask a follow-up question about that too? I think one of the things I wonder about is that there was a movement, within the United States for sure, to access better resources for breast cancer treatment. And it was a large movement. There was a big surge of people's activism. And we have seen that when people are, exert activism and demand more funding and more treatment, we actually have seen that in the United States, and I could give you lots of examples.
Right.
I'm curious if you have a sense for how we will accomplish this for serious mental illness, for example.
I think that one of the interesting things is that I feel that NAMI is an amazing organization, but I feel it is often parents or family members who are advocating at NAMI. It is not always people, there are people with lived experience too, but there's a way it gets fractured that I think is less helpful. So I think the more we bring all these kind of sectors together with hardcore activism that isn't just about families or just about people or just about one diagnosis, but is a broader coalition of people. Mm-hmm. And it's usually often women, right? Why couldn't it be women for this too? It could be, women for mental health, why not? But I do think it needs to have a grassroots feel, but a broader coalition of people.
Yeah, NAMI being the National Alliance for
Yes.
Mental Illness. Yeah. So a broader coalition, such as the kind that you've been working on with Engage.
Well, much broader, hopefully.
And
with
even
lots
broader
of,
than that.
Lots of celebrities and rich people.
So I have another question for you. So I've just, through talking to you, learned about the Bridge trial, which I was unaware of, and it is a very impressive trial. It's very hard to do these kinds of clinical trials. This was an NIH-supported trial, the Bridge trial, and you led it at, as you said, Mass General Hospital, right down the way here in Boston. And it's remarkable, and the results that you showed are excellent, and they were compared with enhanced treatment as usual, so even more excellent because you enhanced the regular care that you compared. So you also mentioned again that this is one single institution, one academic medical center, it's Mass General, it's in Massachusetts, as you point out, more highly resourced than other places. So what do you think will be the next steps to enable this standard of care to begin to expand to cancer care settings all across the United States, which I think is what we would hope to have happen.
Absolutely. Thank you for the question. I think that one of the questions becomes, how do we extend this model to community cancer sites that don't have embedded psychiatry or psychology? What would you do in that case? And one of the promising approaches is thinking about like a tumor board, but rather than it being focused only on the biology of the tumor. Instead, having a person-centered cancer and mental health tumor board, sort of similar to a Project ECHO kind of model that people may have heard about. But the idea here is to bring together mental health and oncology clinicians to build access to psycho-oncology expertise so that the oncologists working in the community site can rapidly access psychiatry expertise. The other good news is that, the pandemic brought us many things. It did bring us more acceptance of telehealth and virtually delivered models. And so we're also testing out a model where the psychiatrist could be for the overarching cancer network, right? And that psychiatry care can be done virtually. That enables us to increase our reach to rural populations, to other underserved populations. It also has helped us to increase our reach globally. I think we also can think about how we're partnering effectively with navigators and other lay clinicians to deliver evidence-based interventions. We have a lot to learn from global work about that.
Yeah, so that's really important, and actually is, in fact, a way to consider a scalable solution. You mentioned Project ECHO, and I'm not sure everybody will know what that is, but you are, considering the idea of leveraging that. And maybe you could just expand upon that a bit so that people understand what that means.
Sure. So, the Project ECHO is a way to build expertise by bringing together a centralized hub with specialists and enabling other people to join that may work in a community site and be experts in their community. So they can join monthly case discussions and learn best practices, and this is an evidence-based way to increase access to psychosocial expertise, to substance abuse expertise, to cancer clinical trials. It doesn't solve the getting the care problem necessarily, but it solves the rapid access to specialty expertise problem. We call it a cancer and mental health tumor board because oncologists know what tumor boards are, and it's important to be culturally in sync with your audience. So it's a sort of similar idea, a virtual coming together to build expertise in community settings.
And the virtual part, just to note, was video conferencing that preceded the pandemic.
Yes.
So it was already happening.
Even in our mini one, it preceded the pandemic. It was
for about a decade or so, I think, before the pandemic. So now even more acceptable than before. So you were talking about moral injury for clinicians, people working in the system, people not being able to do what they know is what they would like to do, what they think is the right thing to do. I'm wondering if you could talk about what you wish all doctors and clinicians learned in their clinical training, and by extension, what do you think, or what do you wish would become a standardized part of clinical training across all disciplines that would enable the kind of care that you're talking about to actually become more routine?
I think that big picture, one of the challenges is the fact that we put mental health care in a different box than the rest of healthcare. And I think if it was incorporated as brain health in a standardized medical school curriculum the same way as other things, that would be a big step forward. I think everybody needs to understand how to assess and respond to a risk of suicide, just like everybody needs to respond to, acute cardiac risk. I think that when we come into medical school, most people are pretty good listeners. When we leave, a lot of people have lost that. How do you change that? Well, I think that the most encouraging evidence is from actually some accompaniment. It could be video, it could be in person, from someone with lived experience of that condition, living with a chronic illness, living with mental health condition, living from the perspective of coming from a different community or identity or being non-English speaking. Those are the presentations people remember and hold on to from medical school. I think that in particular, certified peer specialists do a wonderful job of making that relevant. I think that should systematically be incorporated into medical school curriculums, which it is not.
Yeah. Thank you for that. And actually, I'm going to turn to some of the excellent questions that are coming in. And one of them that's a good, I think, maybe follow-up to what you just said, and I'm just going to read it to you. This person comments, "This is an amazing and powerful talk and striking stories, really, about how good healthcare for mental illness and health should be integrated into in the clinician-physician. So when and how should physicians and other clinicians be trained to understand stigma and shame?
I mean, I think that kids in preschools should be trained to understand shame at preschool. This is a fundamental human feeling. And by bringing things into the light, if you're feeling like you're not worthy of love, that's a human thing. That's not a medical school curriculum thing. And honestly, the better way to move through it is to have a wonderful selection of humanities people right here that help us feel things in our, it's not like us, I can give you your best practice sheet on decreasing shame. It's, you feel for a second what it's like to have somebody feel compassion toward you, and I remember in my kids' preschool, they're amazing. And one of the things they said is like, you all get your feelings. That's right. That's a big thing. Wouldn't that be powerful if we all took that in? Yeah. So I think we need to practice compassion earlier. And I think there's a wonderful opportunity to practice compassion toward our learners. I think sometimes we get lost in this like, and I was pretty hardcore. My training director is here. She'll tell you. I was like, how come we don't all round on the weekends in psychiatry? What's going on? This matters too. So, and I love taking call, but sometimes I think that we're like, there's, medical school training has changed so much. But I think there's this opportunity to think about how we're training about self-compassion particularly.
Yeah.
Self-compassion is an evidence-based approach to counteract shame and counteract moral injury. And I think that would actually enable our clinicians to treat people more equitably, to be able to access that part of themselves more. So basic mindfulness skills, self-compassion, gratitude, but not like you have to. And then, of course, even more importantly, the structural changes that need to happen.
Yeah, thank you. So just to go in a different direction, because there are a lot of different communities and populations who do experience some of the things that you're talking about, shame and stigma, in different ways that may have come from certain other cultures and cultural impact and the way in which people perceive and experience things. So one question is, do you have any experience with Asian Americans and Asian American communities that shame in stereotypical Asian cultures may be defined more as a societal judgment on the individual, and that perhaps they're not capable enough to manage, and that rather than a painful feeling, and how can we help to address that in the context of what you are discussing right now in terms of the cancer care and also mental illness and serious mental illness?
We do partner with the Asian American Mental Health Commission, Cancer Commission, and I think that there are just many different Asian communities, even here in Boston.
Yeah.
We have a Vietnamese community, we have a Chinese community, we have, other communities. I think I don't want to, with humility, I think there are differences within different communities. I do think it's important to note that not everybody feels something as painful. They may feel it as just rejection or not being good enough, absolutely. And I think like what's acceptable to other people is probably different. I think that when things have come up and it's been clear that having a deeper understanding of someone's cultural background might help us to work through something, especially if it's a situation where someone is or isn't getting care. It's been really helpful to partner with leaders in that community and to invite them in to come and do that with us.
Yeah, thank you for that. Another person wondered, they note that they said I'm struck by the finding that the bridge model really helped people's psychiatric symptoms during cancer treatment, and wondered if oncologists more broadly might be interested in the bridge model to increase or to decrease rather the traumatic aspects of cancer treatment itself that many patients experience. In other words, it even has broader implication for cancer care, perhaps for all.
I think that, so I'm a psycho-oncologist, which means like most psycho-oncology is we think it's important to support the well-being of all people affected by cancer. We know that rates of depression and suicide are much higher amongst people with cancer. I think that there's a continuum of services that are important for people. Not all people need a psychiatrist. All people need to be met with some humanity, which is a part of the bridge model that I think everybody could benefit from. But I think that because it's a limited resource, using a stepped model, and acknowledging not everybody needs or wants that.
Yeah.
So we do universal distress screening, but it's important to understand that all distress is not psychological. It could be financial, it could be spiritual, it could be from physical symptoms, and the more we can target what people actually need, the better. But I think what I've learned is that people who do have some vulnerability, who have pre-existing psychiatric condition, or perhaps a substance use disorder, or perhaps something else, it's helpful to kind of already know about them, have that on board, have already had a touch point, because as many of our patients said to us, it's hard to ask for help in those vulnerable moments.
Yeah, absolutely, absolutely. Thank you for that. Here's another question that I think is really important that many of us struggle with. How can we address the national shortage of mental health professionals, and specifically psychiatrists and child psychiatrists? I'm only smiling because it's a big question, and as it is, I think these practitioners are so in demand, it's hard to imagine finding time or finding individuals who could participate in a program like Bridge. So addressing sort of this national shortage that makes it, even to use a program like Bridge, which is collaborative care, how do you find the people given that there is this shortage that we are experiencing in the United States for sure, globally as well, but focused on the US?
I mean, I think we have to think beyond just physicians. I think that we have to think about teams. I think that, unfortunately, sometimes the most complex patients who have the most complex needs are often cared for by people who are the least training, and that's a problem. But if we can set up a model more where nurse practitioners and other people can immediately access specialty consultation, that will increase the reach. And I think like a hub and spoke model like Project ECHO will help us to do that.
Yeah.
We could pay psychiatrists more too. That'd be great.
I think we do have time for at least one more, so we're
Okay.
getting close. So just to go back to some of the language that we use, this question is, how much do you feel that the words we use reinforce stigma and shame? Are there other words or concepts that you think are most important to consider changing?
Yes, our language matters, our words matter. I frequently show a chart with some suggestions. I think that, the most important thing is to ask people what they prefer to be called and let the person from that identity lead you. In general, person-first language is helpful where we're not identifying people by their diagnosis, but instead connecting to more of the humanity. So person with as opposed to schizophrenic. As Mei Wang would say, I like using the word schizophrenic, so I don't want to not acknowledge the nuance of that. And I also think even in our medical record, there's some pervasive things like saying chief complaint or blaming people for not coming to appointments, no-shows, all of this language. We want to make sure that we don't use blaming generalized language and instead use specific terms that are linked to the biology of the illnesses that people have and acknowledge that people are doing the best they can.
Yeah, language is so important, and there's been even studies I know done that show that moving toward person-centered language, people with an illness as opposed to the illness being, the person being just identified as the illness, makes a giant difference. So here's another question. What can family and friends do to help dismantle the shame and mental health discrimination faced by individuals diagnosed with cancer, both during treatment and after remission? In other words, how can you be the most effective person if you're a family or a friend?
I think that normalizing is really important. So just noting that cancer is hard for anyone and that it's common and understandable to need support during that time. I think that it's also important to know that as a family member, you might not have the same understanding of how long it's going to take for your family member to recover, to try to be acknowledge that, and have a conversation about that. I think that's something that clinicians can really guide family members in.
Yeah. I think I'm going to get to the last question because that's all we'll have time for.
Okay.
But it's an important one. How do you? And it's in the same vein. So if you're a family member and your family member has, let's say, schizophrenia, they are not accepting of that diagnosis. They also are smoking, and you want to be the most effective ally you possibly can to assist that person. What could a family member do in that instance? What do you think would be the best way to assist that person?
I think it's really important to meet people where they are. And as a family member, this is even more so important. There's a wonderful book called, I think it's something like I Love You, You're Not Sick, that goes through this in detail. But I would ask, and I do this in our own model, we ask, what do you want? What would you like to be different? What matters most to you? For smoking, oftentimes people are really up for saving some money, so you can just cut down, take some varenicline, evidence-based approach, save some money. You don't have to stop, we don't have to talk about it, you don't even have to be motivated. Maybe just save some money and get some other stuff. So what I'm saying is, like, in the moment, concrete, based on what matters to the person, is where you need to start. And it often starts with small things, and that makes sense, because that's what our days are made up of.
Yeah. So we're coming to a conclusion here, and I just, first of all, really want to thank you very much for the incredibly inspiring talk and the very important work that you're doing, and for this presentation and the discussion we just had. So thank you so much. I also want to thank the audience for their amazing and terrific questions. I want to also say that I hope you will all be able to join us for other Radcliffe virtual programs. You can find out about future programs and watch videos of past events at radcliffe.harvard.edu. And I want to thank everyone again for joining us today, and hope you have a good rest of your day. So thank you very much.
Thank you so much, Shelley.
Thank you.
Thank you.